The following was recorded at the CCHF Conference 2023 in Cincinnati.
Dear God, we thank you for this opportunity to join with like-minded individuals of how we can better represent your kingdom and just help just see your heart more for those that you created and just the world around us. We thank you specifically for Catherine today, and just thank you for all the things and all the opportunities that you've given her and all the people that you've been able to just surround her with, where she's been able to grow to be where she's at today, and then ultimately be able to invest and mentor in her patients and med school students and just everyone in her life. So we thank you for everything you've given to her, and please give her peace and clarity and open all of our hearts and minds as we hear her talk today. Amen.
Thank you, Daniel. Ooh, I shouldn't cry when my little brother prays for me. Okay. So like Daniel said, my name's Catherine Moore. I'm a foster and adoptive mom and a family practice doctor at Affinia Healthcare in St. Louis, Missouri. Today we're going to be doing kind of a bird's eye view of ideas that we can implement in a clinical setting to bless families affected by foster care. We're going to mostly be talking about how to care for kids in the foster care system, but we're going to talk briefly about adults affected by the foster care system as well. If you have any burning questions throughout the talk, feel free to interrupt me. Sometimes I get on a roll when I'm talking and I might not notice you. So if that happens, holler at Daniel. He's been interrupting me his entire life, and so he's well versed at that. But otherwise, hopefully we'll have time for questions at the end. So I have no financial disclosures, but there's one thing that I want to point out as we get started. When it comes to my position within foster care, I am a physician, I'm a foster parent, and I'm super white. And that individually, each of those three things puts me in a position of power within the foster care structure and system. And so as you're listening to this data, please consider ways that you can listen to the voices of foster youth, former foster youth, and families that have had their children removed from them as you make your policies. Please don't let my voice be the main voice guiding you. No financial disclosures. And I don't have any more disclosures, but I do want to start the talk with a confession. I didn't become a foster parent from a pure and holy place. When I started my medical career as a medical student and then a resident, I was really upset at the abuse and trauma that I saw my patients face. I would come home almost every night and I would cry, and I would look at scripture and I would say, God, I know that your word says that you're a father to the fatherless. I know that your word says that you uphold the cause of the oppressed. I know that your word says that you defend the widow, that you put the orphan in homes, but I am just not seeing it. I'm not actually sure if you're holding up your end of the bargain. When I was an intern, I was on the pediatric floor and I took care of a little girl. We'll call her M, and she was literally only in the hospital because there were no foster families available to manage her insulin. Each time she would get discharged from the hospital, she would end up back in the ER within a week in diabetic ketoacidosis. Or if she didn't end up back in the hospital, the foster family would return her because of her excessive urination. Now, even our newest med students in the room know that excessive urination is a sign that your blood sugar is entirely too high. So she was being punished because of a symptom of her type 1 diabetes. So little M was in the hospital for probably around 2 months, and I was with her for one of those months. I had the privilege of helping her plan and celebrate her 10th birthday in the child life room. She made little plastic bracelets for everyone in attendance, and I still keep mine on my dresser to this day. It's starting to crack and fall apart, otherwise I would have brought it with me. Every night I would go home and I would cry, and I would try to scheme up ways to bring her home with us. And my husband would say, "You're an intern. I'm in grad school. We don't live in Illinois where she's from. We're not foster parents. You can't just take her home. That's kidnapping." And at the end of that month, the Lord spoke to my heart, and it was the first time I'd ever heard the voice of God. And he said, "Not this child, but there will need another one that will need you to care for them." Fast forward to this is on a timer and I didn't realize it. Fast forward to my chief year, and my husband and I welcomed a little almost 3-year-old boy into our home. He was unable to walk or talk because of years of neglect. One night shortly after his 3rd birthday, I was kneeling next to his bed as he said his evening prayers, and he said, "Thanks, God, for scooting a little closer." Thanks, God, for scooting a little closer. So this is the framework that I want to consider how we can care for foster care, people affected by foster care in our clinics, because we serve a God who truly does scoot a little closer to the fatherless. He scoots a little closer to the oppressed, and when we consider how we can care for them well, we are joining with the Almighty God. So I just want to start by reading this goal of foster care, because a lot of people don't realize that the goal of foster care is to reunite children with their biological families when it all safe and possible. And that's been a big problem we've encountered in medical spheres. So I'm going to just read this word for word because it's that important to me. According to the Missouri Department of Social Services, the goal of the child welfare system is to protect children and provide services to help them stay at home. When the court decides that staying at home is not in the best interest of the child, they may be placed in out-of-home care, also known as foster care. Foster families provide safe and caring temporary homes for children while their family works towards their goals and reunification. You might be thinking to yourself, I'm not a foster parent, or maybe you are, or I'm not a social worker. What can I do to help? Well, the medical need is pretty staggering for kids entering foster care, with about 80% of them with documented history of neglect or abuse, 50% entering foster care with chronic physical problems already, 10% are medically fragile or complex, and 40% have oral health needs. About 80% enter the system with significant mental health needs. About 80% of the children have been exposed to significant violence. About 15% of children who enter foster care have fetal alcohol syndrome. About 60% of kids under 5 years of age have developmental delays, and over 40% of school-age children have educational problems. Daniel, can you come mess with this while I'm talking to get this to stop doing this? About 80% of the, I already said that part. Early childhood trauma can lead to poor emotional regulation, impulsivity, aggression, attention attachment problems. And as a result, foster children are prescribed psychotropics 3 times more often than their equal Medicaid peers. Okay. All of those sound like issues that many of us have been trained to address, right? Right? Okay. But there can be barriers to providing excellent care for kids in foster care. It can be really time consuming. A lot of the time their healthcare records are fractured and incomplete. You might have questions about consent, who to get permission for what. And you may have inadequate resources, and sometimes you're limited by the insurance itself. When I was preparing this talk a few years ago for the first time, I asked one of my friends who's a medical nurse, case manager within our local foster care system, okay, Nurse Sherry, if you could design the perfect clinic to care for kids in foster care, what kind of characteristics would that have? And so Nurse Sherry offers these to you. It would be a clinic that offers a medical home model, a clinic that is able to readily identify community resources, an organized clinic that can maintain appropriate consent forms that are signed, a clinic that has consistent EHR procedures, a clinic that is willing and able to communicate with caseworkers and foster parents, and a clinic that is educated on the effects of childhood trauma and adversity on childhood health so that they can reframe child behavior in the context of trauma and toxic stress. You may be wondering, are there guidelines for this? In medicine, we're always looking for excellent evidence and guidance from the powers that be to provide excellent care, right? Thankfully, the American Academy of Pediatrics has published policy statements and guidelines to help us provide excellent care for kids in foster care. And at least in our state of Missouri, these are recognized as the official guidelines for care of the foster child, and in most states, it's the same. So here are a few of the highlights that we're going to touch a little bit more on. So healthcare goals, according to the AAP, are that a child must be seen within 24 hours of entering care. They require 3 healthcare visits within the first 3 months. Medical records are to be incorporated into the permanent Children's Division record. They recommend an accelerated scheduling based on age. So from 0 to 6 months, they recommend that a child is seen for a well visit every 30 days. From 6 months to 24 months, they recommend that a child be seen for a well visit every 3 months, and over 2 years, every 6 months. They also recommend additional visits with transition of caregivers, like if a child returns home, that they have a clinic visit around that time to support the family, or if they switch foster care providers or something like that. And they also recommend, when possible, that we provide additional office visit time. So now we're going to get into some of the nitty-gritty details of those first 3 initial assessments, because they're a little different than some of our normal PEDS visits. So the initial medical screen's purpose is to identify health conditions that require prompt medical attention, such as acute or chronic diseases requiring therapy like asthma, diabetes, seizure disorders, signs of abuse or neglect, signs of infection or communicable diseases, hygiene and nutritional problems, pregnancy, and significant development or mental health disturbances. And part of this is in order to identify health conditions that should be considered in making placement decisions. So an example of how this came up in our family was there was a little girl who came into care, and she was at her initial health screening. A lot of these in our area are done in urgent cares because it's just kind of hard to get into some of our pediatric clinics within 24 hours at last minute notice. And it was noticed that she had an upper respiratory infection. Now, 3-year-olds are just full of snot anyways, right? And so it's not uncommon for a child to have an upper respiratory infection. But the foster family that had accepted her placement, one of the family members was undergoing chemotherapy. And so the decision was made that she should be moved to a different family. And so our family received the call and asked if we could have her join us for a little while until biological family was prepared to take her. So that's how little tiny T joined our family. All right. You think you figured it out or no? No, it's still just going to do whatever it wants. So then we're moving on to the comprehensive health assessment. Oh, nope, I wanted to say something more about this last screen. So a lot of the foster families don't know anything about the child at this point. They're, barely making it to the appointment. So to the best of your ability, review health information, trauma history, review of symptoms, and a very symptom-targeted exam. Brief child abuse screen and developmental screening, as well as mental health screening. If it's a child of menstruating age, you might want to do a pregnancy test and STI testing for other children. And then you're just going to work on a quick, appropriate treatments and referrals. You're going to try to communicate with the caseworker if at all possible, find out if they want to get a fax with your master note, or if they want a quick phone call. And then you're going to do anticipatory guidance related to foster care, the traumatized child, and specific diagnoses that the child might have. So moving on to the comprehensive health assessment, it's exactly what it sounds like. It's a more comprehensive assessment. So you're going to review any available health information that's been able to be gleaned on the child in that last 30 days, and we'll touch on that in just a second. We will identify acute and chronic health conditions, identify developmental and mental health conditions, do a more formal trauma assessment, and to develop an individualized treatment plan. So gathering records can be pretty tricky. The first place that we usually start is by asking the caseworker if they know if this child has had a pediatrician before or if they've been to any particular ERs. Another way that we get a lot of information is by looking at insurance claims data. So at least in Missouri, and I think in a lot of other places, you can log on to the Medicaid database, and we kind of do some sleuthing to see who's billed for what. Like, a lot of times that's how we find out what vaccines they've gotten or which clinics we should request records from. Hospital EMRs have been very helpful for us. And some of this data gathering can be even more distilled based off of region. So in St. Louis, the comprehensive health visit is done at 2 of our children's hospitals, so my clinic doesn't actually do any of these. For 0 to 12-year-old kids, they're all done at Cardinal Glennon. And I think it's 12 to 17-year-olds are seen at the Coach Spot Clinic. So their staff leading up to this 30-day visit is doing a ton of investigative work, trying to figure out where the child has been seen and what we know about their care. So at this visit, you're going to review any of that available health information, including a trauma history, why they came into care, and do a lot of different screenings. try to get an idea of their school performance, at least what the foster family knows, and how they've been doing in this month. Do a review of the immunization record that is able to be gleaned, do a review of symptoms, and a complete physical exam down to the skin. For adolescents, you want to add family planning and sexual safety counseling. In some cases, you want to do that for younger as well, not just adolescents. The AAP recommends that you do HIV, Hep B, and Hep C testing on all kids that come into care, and all kids under the age of 6 to add on a lead and H&H, and then consider PPD, RPR, UA, hemoglobin, and hematocrit, and anything else is clinically appropriate. Another thing that I failed to mention on the slide before is sometimes biological family members are present at the visits when it's safe for the child, and so that's a great opportunity to learn the child's history. For one of our children, that's the only way we know anything about his biological family and family history, is what was learned by the provider at those early visits. So at the close of this appointment, you're going to do, again, appropriate treatment and referral. You're going to communicate with the caseworker, do any anticipatory guidance, particularly around parenting the traumatized child, because usually by 30 days, the parent is starting to get a little overwhelmed by the needs of their child, or at least we have been in the past, and then schedule the follow-up visit. The follow-up health assessment, the goal is to have that scheduled right at the end of their first 3 months in care. The goal is to continue identifying acute and chronic health conditions. And now you're starting to look. You've gotten to know this kid a little bit better, this foster family a little better, and you're looking for ongoing stressors in this child's life. You also have the opportunity to observe for goodness of fit with the foster family. Observe how the child and foster parent interact with each other. Observe if the biological family is present. Observe how the biological family and child are interacting. Now, when you document this, I want it to be super objective. Don't let your feelings or ideas about the situation in the particular case get in the way, but be very objective. You know, you can say, patient, sits on mom's lap, seems comfortable and safe, or, something like that would be appropriate. You're going to update immunizations. You're going to provide health education. Hopefully by that time you're already getting back some of the referrals that you placed at one of the first 2 visits, and can integrate that into the patient's care and plan. You're going to keep on updating treatment and referral, keep on doing anticipatory guidance, keep on communicating with the caseworker. See some excellent themes here. And then schedule any other follow-ups as necessary. So at all clinical visits, we want you to be very cognizant and paying attention for signs of abuse or neglect. We're not naive to the fact that kids in foster care are often abused at the hands of their foster parents. And so please be on the lookout for things like poor weight gain, lack of warmth, frequent missed or canceled appointments, and failure to comply with recommendations. And then most things are just like, from there, are caring for any routine PEDS visit. You're going to be doing age-appropriate hearing and vision, lead screenings, H&H, height and weight, skin evaluations as appropriate, education, and updating vaccinations. So the AAP recommends that if you aren't able to get a vaccine schedule on a child, even after your due diligence, it's to assume that they are vaccine naive and initiate a vaccine catch-up schedule. The electronic health record can create a little bit of confusion for families affected by foster care, starting with registration. So what do you put as the child's address? Most of the time it's okay to put the foster parent's address, but we've had some situations where biological family has gotten the foster family's address and aren't supposed to through the child's electronic health record. So in some cases you may be asked to use the foster care agency as the primary address for the child. The foster care agency and caseworker should be listed as an emergency contact in the child's chart. For billing, at least in our area, we've been asked to use the foster care agency in the state of Missouri as the guarantor, because they'll cover all the fees for the child. Those won't end up with the foster parent. And if you have billing problems, the foster family may or may not know the answers to those, so you might need to direct them to the caseworker. And then transitions of care, like when a child moves to a different foster family, returns home, or goes to kinship placement. It's great when a clinic has process to update that type of information. We have one particular children's hospital that we have a child that goes to for specialty care, and no matter how many times this child is no longer in foster care, there was termination of parental rights due to safety reasons, and no matter how many times I remove his biological family's contact information from the record, it repopulates. And going on to the next problem with the patient portal, so in some places, foster parents can't be a proxy on their foster child's chart. Only biological family can be. Now, there's been some changes with that with the pandemics, with the necessity of using the patient portal for telehealth visits. But because our son's biological mother and us are both linked to his portal, I get her doctor's appointment recommendations, and I shouldn't be getting that. Like, that's a violation of her privacy, you know, so, like, I don't understand computers at all. Clearly, it keeps on advancing without me. But that has been a huge issue for us at multiple hospital systems with our children, as well as some issues have come up with this in our clinic. For most of the time with consent, the biological family, or the foster family can consent to most things that are happening within an office visit. Check your state and local rules on this. For example, when we've had foster children in our home that have required sedation or procedures, that actually requires a judge to authorize that. And so there's been times when we've had medical placements in our home that required an MRI, but we had to wait for a court date for the judge to be able to sign off on a sedated MRI. So again, you just might have to ask the caseworker what the rules are in your area, but that's what it is for us in St. Louis. Yes, ma'am.
Is that the same for vaccines, like their regular vaccines?
No, vaccines, at least in Missouri, vaccines are part of prudent parenting, so foster parents are actually, this has been interesting because we've had some foster parents that are anti-vax. And so they actually have to sign off on vaccines even if they are morally conflicted, because the foster system wants them to be caught up on vaccines before they go home. So yes, good question. Those are considered just prudent parenting, okay for the foster parent to sign off on. As far as billing and coding, it's not entirely different from any routine PEDS visit. I do ask that you include the Z code for child and welfare custody in your assessment, because that's how the state Medicaid will know to pay you at that accelerated rate for wellness visits. They won't pay you for that double wellness visit unless you include that code in the assessment and plan. And I've been told that that's pretty standard across different states, but I know that holds true for Missouri. And again, call the case manager, not the foster parent, for billing issues. I still get called for billing issues for my kids because my kids are seen at my clinic. Now, there's been a few times so far that I've mentioned specific anticipatory guidance on the effects of trauma, and you might have found yourself wondering, that's not part of our after visit summary, like anticipatory guidance deck. Where can I find those handouts? Well, luckily the AAP thought of that too. So I've provided the link for the trauma toolbox, and there's a lot of great handouts in there for both providers and parents who are parenting kids who've come from hard places. And if you're trying to take pictures of the screens and they advance without you, all of my slides are on the app. So these are great resources for both medical providers and parents. And when we're thinking about kids who've suffered trauma and we're doing all these developmental screens and we're trying to figure out how to help them the best, a lot of times you identify a lot of areas where they're behind, right? At least in our case, that's been true. I like to think about our kids who've come from hard places like a giant puzzle. So I'm thinking of my son in particular in this case. When he came to us, he was globally behind by about a year, particularly in speech, fine motor and gross motor, but highly advanced in emotional intelligence. And obviously, his life experiences far outweighed his 2 years in life. And so all of his puzzle pieces were a little bit different age. And so it's really important that we meet our kids where they're at, no matter what their age is, and meet each of their puzzle pieces where they're at, no matter how old they are. I'm happy to report that he is now at grade level for everything. And we've got some unique challenges, but he's been doing phenomenally, and we're so proud of him. When we have families affected by foster care in our clinic, it's really important that we remember that kids are listening to everything we say. And even when we're seeing these horrible situations that some of our kids are coming from, they love their families of origin. Even if they've suffered abuse at the hands of their family, a lot of them long to be back with them. So there's a lot of things that can be said to foster families or foster kids that when you think of it from that perspective, think of it as a kid who really wants to be back with their mom, or a mom who desperately wants to get better so she can be reunited with her child. It causes us to say things a little differently. But I have a brief list that I'm going to share of things that have been said to my husband and I when we've been in medical offices by medical staff, and I'd encourage you not to say them. They're so lucky to be with you. I guarantee you my children don't feel lucky to be separated from their families. I bet their mom is a teenager or on drugs or a prostitute. Don't you want your own kids? As long as these kids are with me, they are my own kids, okay? Do you get to keep them? What are they, a puppy? I'm sure you'll get pregnant with your own kid any day now. Which one is your real child? You foster children, I foster dogs. We're twins. I guarantee you my children do not like to be likened to a dog. How long do you find out if you get to adopt them? I could never be a foster parent because I would get too attached. What about me? Don't you think I get attached to them too? You may be wondering what happens to children when their time in foster care is over. Well, about 50% of them are able to return home. 6% are able to live with other relatives, and about 10% find themselves in a guardianship situation. About a quarter are adopted, and 10% age out or emancipated. In my current job, I mostly take care of adults. When I'm doing a social or trauma history and I find out that an adolescent or an adult was in foster care, that's super clinically relevant to me because former foster youth are at high risk of a lot of different things. They're at higher risk than their peers of human trafficking, homelessness, incarceration, substance use disorder, employment issues, and themselves having kids in the foster care system. This said that 9% of alumni of foster system had children in care, but about 50% of kids that have been in our home had parents that were in foster care themselves when they were younger. There are also unique issues that come up when you're taking care of adults who themselves are adoptees, were adopted, whether as an infant or out of the foster system. So they often have incomplete medical records. A lot of the times they have poor knowledge of family medical history. Many of them have ongoing symptoms related to trauma, particularly somatic symptoms. Many have mental health concerns. They're 2 to 6 times more likely to have received a referral to a mental health provider than their peers. And adoptees have an increased risk of suicide with a 4 times higher risk of suicide than their non-adopted peers. I get to take care of many adults who are caring for kids affected by foster care, and it's such a joy and delight to walk alongside of them as they figure this out. So families providing kinship care, foster families, families in a guardianship situation, which the rules of that will vary by state, so we're not going to touch on that so much, and then adoptive families, and then biological families. In general, for this whole group of people, it's important to know what medical requirements are in place in your state for care providers, and a general knowledge of how the system works in your area. So an example of how this looks for me is I know where to find the medical form on the state website. Because have you ever been going to your own medical appointment and you got the kids babysitting, or you finally got into your PCP who had a 2-month waiting list, and then you get there, you wait for 30 minutes, and then you get in and you realize that you left the form on the table? There's nothing more frustrating. And so it's a really easy thing for me to say, don't worry, I know what that form is. I'll just go print it out and fill it out for you. Also, there's a lot of really excellent parenting resources available. Parenting children from hard places can be can present some unique challenges and can be incredibly stressful as a parent sometimes. A resource that's been a huge blessing for my family is the Empowered to Connect curriculum out of Texas Christian University. And I see Dr. Diana over here in the corner, and she gave an awesome talk last year with a lot of great resources for parents and teaching parents. And I need to incorporate those more into how I speak to families, so I'm really glad you're sitting in the front row. Another thing to be conscientious of is they too may be experiencing trauma, like secondary trauma through their kids, and may have no idea that that's even what's happening. And so being able to reflect back to them how you're seeing this stress exhibit in their lives can be really life-giving. Even just acknowledging it and learning how to give it a name can be really helpful. That brings to mind one of my patients who has recently gotten guardianship of his sister-in-law who has cerebral palsy, and he did not have any idea that his difficulty with taking his blood pressure medicines all of a sudden and his worsening chronic pain, it didn't occur to him that that correlated when his sister-in-law moved into their home and all the struggles with guardianship and her insurance and her hospitalizations. And so I was able to reflect, hey, you know what? I think this is taking a toll on you, but we're here to support you because I'm so thankful that you're able to provide for your sister in this way. I'm so glad that we get to support you in this. So the most important thing is providing empathy and support. So let's talk a little bit more about a few of those groups in specific. So it is such a joy and privilege to support biological parents as they're working their plan to get their kids safely back in their care. So a lot of the ways that we can help in this way, I mean, we can be a non-judgmental listening ear, right? But we can also look back into why the kids came into care in the first place. So if you have a substance use treatment program at your clinic and their kids got taken away because of a parental opioid use disorder, perhaps you can work with the courts and she or he can receive care right there in their own primary care clinic. Or for alcohol use disorder, or maybe you have an outreach team that has a lot of housing resources and mom can't get the kid back until they have adequate housing. We're walking with a family right now, and that's the last barrier for the dad. He has to have safe housing for these 3 teenagers, and then they'll be able to come home. And so we're working with community resources to make sure that they have a safe place to go. And so I'm hoping that when we get home, that's in place for them. Our clinic is working on resources to receive folks when they're coming out of incarceration. So that transition can be really rough when you've been incarcerated, bam, and then you're back out in the real world and you're expected to get everything together to get your kids back. Any way that you can support a parent, even if it's just with the medical piece, coming out can be a huge blessing. We get to be their cheerleader, and that's such a privilege. I'm walking with a dad right now. I'm providing his mental health care, and he just had a court date, and it was a long anticipated court date. He's done really, really well. He's been sober for quite a while now. He was anticipating going into court last month to find out that he was getting his kids back. But he went into court and the judge said, "You're doing great. We're so proud of you. Come back in 120 days and we'll tell you what the next step is." As you can imagine, he was crushed, right? And he relapsed that night. That doesn't surprise any of us, right? But I get to walk alongside of him and encourage him and support him and say, you know, this does not define you. You're still a loving dad. You're still working really hard to get your kids back, and we'll keep working towards that. A lot of these parents don't have anybody in their corner. Nobody believes in them. Nobody believes that they can get their kids back, but we do, right? We believe in them. Kinship care is really near and dear to my heart because many of my patients are incredibly compassionate people who provide excellent care for people within their own family who've entered foster care. About 33% of kids in foster care are in the home of a relative or close family friend. This is actually really common in the African American population. They do a better job than any of the rest of us at caring for their own. And it's really important to acknowledge that. Kinship care is important to support because children who are placed in kinship foster care experience fewer behavioral problems, fewer mental health disorders, and fewer placement disruptions than kids in traditional foster care. The problem is that there's also data to suggest that relative caregivers are more likely to be single, poorer, have less formal education, and have more chronic health conditions, mostly because many of them are advanced in their age. And relatives are also less likely to be aware of financial benefits. So not very many know that a lot of cases they can receive help from the Temporary Assistance for Needy Families program. And less than 50% of kinship foster care providers in low-income families don't receive SNAP or WIC or Medicaid health coverage. So what this looks like for me is when I find out that one of my patients is taking care of her great-nephew, I make sure we walk right to the WIC office on the way out and right to the Medicaid enrollment office to make sure that they don't walk out of here without finding out if their kid is eligible. I was just talking to a sister before the program about how sometimes we have the case where we're taking care of our family members without getting any support, where there's been an abuse or neglect family case within the family, but it either hasn't been reported to DCFS because of concern for privacy, or it has been reported to DCFS and DCFS isn't doing anything because there is some family support involved. And so sometimes that can be really tricky and really sticky to get kids the care they need and deserve. There was one case where I didn't even know that my patient was starting to take care of her great nephew until I saw her A1Cs get worse and worse and worse. I said, "What is going on? You've always had perfect diabetic control." And she said, "You know, my niece dropped off my nephew and I can't even enroll him in school because I don't even have the correct authorization to sign those forms, but she won't give it to me." And so there's been cases where we've had to get our legal partners involved to advocate for the kids and for the family members taking care of the child. All right, I'm being told that I need to wrap it up. So we'll end with advocacy. You might be thinking, okay, all of those are great things, but I want to do more, and I'm so glad you're thinking that way. So one of the most important things we can do for kids who are affected by foster care and their families is to leverage our privilege on their behalf. So what this looks like for me is I prioritize trips to our state capitol, and I make sure that all of my local legislators have my cell phone number, so that if anything comes across their desk that involves foster care or adoption, and they have a question, they know they can call me. Not a single one of them has taken me up on my offer yet, but I prayerfully hope that they do. I've also recently been appointed to sit on the Missouri Medicaid Show Me Healthy Children advisory panel, and so I'll get to help make decisions on what things get covered for kids affected by foster care at a statewide level. So I'm really excited for that. In conclusion, I hope that this presentation got your wheels turning a little bit. It can't be conclusive. This is 8 years of my life experience, so I can't fit that all in 30 to 45 minutes. But I hope that this gets you excited to meet with God in the care of families affected by foster care. The American Academy of Pediatrics has a lot of great resources to help you improve the care you provide. I'd also encourage you to be thoughtful about everything that goes on in your office, from the registration desk to the casual words that you say, because everything we do matters deeply for families affected by foster care. And with that, do you have any questions? These are my beautiful children. 3 of them are adopted through foster care, and the 2 little ones on the end, Riverlyn, we just celebrated her adoption last Tuesday. And Levi DeWaylen, we celebrated his adoption in February. We're honored to be a part of their story. Okay, we'll start up here and then go back here.
How closely do you work with the foster parents when children come into the care? Are they involved in when you provide services for them? Are they included? Are they asked questions? Children that are in care? How involved are they?
The question is, how involved are foster parents in the actual care of the children? They should be incredibly involved. They should be caring for that child's medical needs and medical care exactly as if they were their biological children. Obviously, there's some outside players. I've been co-parenting with the state of Missouri for a really long time, so I have to consider what they say and what the judge orders. But they should be. And when I was talking about assessing for goodness of fit with that comprehensive visit, if you have concerns that they are not advocating for that child and they are not looking out for the best interest, I would encourage you to call the caseworker and make sure that there's a formal concern listed, like that's documented. Does that answer your question? Okay. All right, back here and then over here.
You kind of touched on it, but so your kids can be seen in your own clinic as long as they're on Friday. Is that kind of like the 24-hour visit as well? They can be working with those Friday in your clinic? Is that allowed?
That's never come up for me. I personally choose not to care for my own I don't think there's anything illegal as long as there is an identified patient-physician relationship. But I missed anaphylaxis in my own kid because he's my own kid, and I was like, nobody in my family has anaphylaxis. Why would my kid be having anaphylaxis to dairy? That's ridiculous. Cheese is my main food group. So I choose not to provide any care for my own children. However, I am a medical foster parent because judges listen to me more. I could give many examples of that where a judge has recommended something that's medically ignorant, and I've stood up in the court and said, absolutely not, we will not use our tax dollars for something that's not evidence-based.
What were some of those resources that you kept bedside or chairside as you started your journey of caring for patients and families, kinship providers?
So that trauma toolbox has been really helpful, the AAP. It was really interesting actually because I gave this talk at our residency program when I was a new foster parent and a chief at our residency. I gave it as part of our ground rounds. And so at that time, I read all of those policy briefs. I knew them inside and out. But I haven't read them in a couple years. And so I was preparing to give this and I scanned over it. And I was like, after a while, you just kind of, especially if they don't update them, it's just part of your clinical care, just thinking. And a lot of the time, I think now we're thinking a lot more carefully and thoughtfully about trauma-informed care in general. So thinking about how to incorporate the ACEs into our exam room. One of my students was like, Dr. Moore, you need to have a whole part of this talk on ACEs. And I was like, how long do you think I have? I think that a lot of that a lot of the way we care for people in general is becoming more and more trauma-informed. So I think that things that I once had to have at bedside, I think are becoming more common practice in our care that we provide. Yes, ma'am.
Have you found like a situation where the parent got yourself together and gave the kids back, and then to find that the children are being misused? Is it a lot harder to go back to court and get that started over again?
So that exact situation hasn't happened in my family. That hasn't happened to any of the kids that have been in my care. But the short answer from observation is yes. It's a lot harder to watch a kid go home and then come back. In our case, the closest thing we've had to that is a kid came to us and then went to biological family and then came back into care, but we'd already filled those beds, so we weren't able to take her back, and that broke my heart. Like, I wanted to be the one to take care of her, but the medical needs of the child we had at that time were too much, and it was the beginning of 2020, and I was running a COVID unit, and I've never had a harder no in my life. Yes, ma'am.
Have you ever done shared parenting with the biological family for the children that you had in foster care?
I wish. That is something that I long for and have prayed for, and it has never happened. But my best friend, who's a foster mom, has had really beautiful relationships with the biological family for her kids. What my husband and I always pray for our kids is that God would give us the fullest reconciliation that He's willing to grant on this side of glory. And in my mind, that's the most beautiful thing. But no, that hasn't happened for our kids. Our most recent adoption happened because our kid's mom was very ill and ended up passing away. And so their grandparents said, we can't take care of two toddlers. Can they stay with you as long as we're able to stay in their lives? And we said, absolutely.
So even the ones that you fostered that did not stay or weren't adopted, you never had the experience of shared parenting with those people?
So our case is really unique. So we've been foster parents for 8 years and have only had 7 kids. So that's very atypical. So all of the short-term placements that we've had, they've been very short-term. Like, the only role that we've played is in keeping the kids safe while grandma, aunt, uncle, whoever gets everything, like gets a toddler bed or whatever, so that the kids can go to them. Yeah. And then our long-term cases all were from very complex traumatic situations that the kids weren't able to return home. So I wish for that. That's what I hope for and pray for, and we have not been able to do that. Yes?
In regards to medical records, that you talked about how they can be fragmented sometimes, and should have a case worker or someone that needs to be referred to. Have you found any tips or helpful ways of trying to reconcile medical records, like from multiple systems or things like that?
Yeah, so the question is about reconciling medical records and tips and tricks. I mean, my main tip and trick is to have Cardinal Glennon Children's Hospital have wonderful, compassionate nurse practitioners sitting at a desk doing data mining all day. We're really spoiled in St. Louis. I don't do a lot of the data mining myself. Make friends with that team, or if that team doesn't exist for you, make it. Because that program started, it was actually initiated by a trauma investigator, physician in our area, and he's also on the committee that I've been elected to. And that has just been a game changer for providing excellent care from the bat for those kids, figuring out where their medical home is, try to keep them in their medical home from the get-go, keep them with their own pediatrician. Like, I mean, that's been a lot easier to do lately. Yes, ma'am.
So I'm a family doctor here in Cincinnati, and my husband and I are in the process of becoming licensed foster parents. My question is, as a physician with a demanding job, and my husband's not a physician, but he works full-time as well, like, how do you balance, like, I feel like a lot of the foster parents I know are like, one person's a stay-at-home parent or works part-time, like, logistically, how do you do it in a way that's honoring to God and honoring
Yeah, you might not like my answer. My husband quit his job.
Okay.
Yeah, because, so we started fostering when we were both full-time grad students, and we did that for a while, but when our second son was born and he had life-threatening food allergies, we realized that we couldn't quite keep doing this, and when the Lord asked us to keep our foster care license open, we were like, we can't juggle all of this. So my husband is a PhD stay-at-home dad who volunteers in community development. He's the best person I know. Although everybody's always like, oh, he's so organized and he's so involved and he's such an awesome dad. I'm like, I mean, he's a dad, doing dad stuff, being awesome. This should be the standard for dads. Not the stay-at-home dad part, but like just excellence in parenting. He'd be so embarrassed if he knew I said that. Any other questions before I pray us out? All right. Lord, I just want to lift up the group before me right now. I pray that you would place an individual person, whether it be an adult affected by foster care or a child affected by foster care, or a child who is in distress, who's not in foster care that they're really worried about. I ask that you would center that person on their heart right now. I ask that you would be near that vulnerable person, that you would remind us that you are near to them, that you are seeing them, that you are providing their every need. Please help us be part of the answer to their prayers right now. I ask that these clinics would be blessed and empowered to care well for families affected by foster care, that we would truly see the fullest of your reconciliation that you're willing to grant us on this side of glory. And we ask these things in the name of your Son, Jesus Christ. Amen.